All right, let's dive right into this. Today, we are tackling a seriously complex, multi-system condition that pops up all the time in clinics. And honestly, it serves as a truly fascinating medical puzzle. We're going to break this down using a structured, visual approach so you can master the pathophysiology, the key clinical signs, and those absolutely crucial high-yield takeaways right along with me. Picture this. You're in the clinic, and a previously healthy 10-year-old kid comes in because they've just gradually started stumbling. Now, at first, it's super easy to write that off as just a clumsy phase, right? Kids trip over their own feet while growing. It happens. But over the next few years, walking gets increasingly difficult for this patient. The child starts developing slurred speech, spinal deformities like scoliosis, and a noticeable loss of sensation in the feet, eventually needing a wheelchair. And then a really devastating complication hits, hypertrophic cardiomyopathy. So you have to ask yourself, what exactly is the missing puzzle piece here? What single root cause connects the degeneration of the nervous system, the structural remodeling of the heart, the failure of the pancreas, and these skeletal deformities? It's a pretty striking clinical mystery. And the answer? It's Friedreich's ataxia, the most common inherited ataxia out there. Here's our roadmap for today's explainer. 1. The clinical mystery. 2. Genetics and pathophysiology. 3. Neurological clinical features. 4. Heart and systemic complications. 5. The gold standard diagnosis. And 6. Treatment and exam pearls. Let's get moving. Section 1. Genetics and pathophysiology, the root cause. Okay, so by definition, Friedreich's ataxia is an autosomal recessive, progressive neurodegenerative disorder, and it's caused by a deficiency of a highly specific mitochondrial protein known as frataxin. Now, because it's autosomal recessive, both parents are usually completely asymptomatic carriers. They have no idea they have it. For every pregnancy, there's a 25% chance of the child being affected. But what's actually going wrong at the DNA level here? Well, the culprit is a mutation in the FXN gene. And this is a massive, high-yield fact for your exams. The vast majority of these patients have a GAA trinucleotide repeat expansion, and it's located right within intron 1 of that gene. You absolutely need to lock in GAA in your memory. This repeat expansion basically trips up the cell's machinery, which leads to a severe drop in the production of that frataxin protein we just talked about. And that drop creates a fascinating but totally devastating cascade of destruction. Normally, frataxin is basically the MVP for mitochondrial iron homeostasis and making sure the cell has enough energy. But when frataxin is deficient, iron just starts accumulating uncontrollably inside the mitochondria. Actually, think of it like a rusting engine. All that iron buildup starts generating a massive amount of reactive oxygen species. This oxidative stress acts literally like biological rust, systematically destroying neurons and cardiac muscle cells, which leads right to the progressive disability we see in these patients. Section 2. Neurological clinical features. The brain and nerves. Now, this oxidative stress targets some very specific neural pathways, and the cool part is you can map each damaged tract straight to the clinical symptoms. So the posterior or dorsal columns degenerate, and that gives you a profound loss of vibration and joint position sense. Then the spinocerebellar tracts degenerate, which results in that hallmark progressive gait and limb ataxia, poor balance, and the frequent falls. When the corticospinal tracts get damaged, you eventually see weakness and spasticity. And finally, the peripheral nerves take a hit, causing a sensory axonal neuropathy and that classic positive Romberg sign. Now get this. Here is an almost paradoxical combo of reflexes you'll see during a physical exam that might make you do a double take. Typically, you're going to find absent deep tendon reflexes, especially absent ankle jerks, and that's because of the peripheral neuropathy. But despite those reflexes being totally gone, you will often see an extensor plantar response, a positive Babinski sign. Why? Because you simultaneously have that corticospinal tract involvement we just talked about. Absent ankle jerks plus an upgoing toe, that is a huge exam pearl for Friedreich ataxia. Don't forget it. Section 3. Heart and systemic complications. Beyond the brain. Keep in mind, frataxin deficiency isn't just a brain issue. It totally wreaks havoc on cardiac muscle and pancreatic beta cells, too. Hypertrophic cardiomyopathy is incredibly common here, and unfortunately, cardiac disease, whether that's heart failure or fatal arrhythmias, is actually the #1 cause of mortality for these patients. On top of that, about 10 to 20% of them will develop diabetes mellitus because of the damage to those beta cells. You'll also frequently see skeletal issues like severe scoliosis, plus really distinct foot deformities like pes cavus, which are those exceptionally high-arched feet, and hammer toes. Section 4, the gold standard diagnosis. Solving the mystery. So when a young patient presents with ataxia, absent reflexes, and pes cavus, your clinical suspicion is obviously going to spike. To build the case, we look at a few preliminary tests. But here's an interesting trick. An early MRI of the brain might look deceptively normal. Unlike other ataxias, you might see minimal to almost no cerebellar atrophy early on. Nerve conduction studies, though, will typically show that sensory axonal neuropathy. And you absolutely must order an ECG and an echo to check for that life-threatening hypertrophic cardiomyopathy, plus routine blood tests like fasting glucose and HbA1c to screen for the diabetes. But listen, clinical clues and preliminary tests can only get us so far. The ultimate judge, the absolute gold standard for diagnosing Friedreich ataxia is molecular genetic testing. You have to prove there is a pathogenic FXN mutation. And as we hammered home earlier, that is almost always going to be that infamous GAA repeat expansion. Section 5, Treatment and Exam Pearls, Mastery. For the longest time, there was literally no cure. Just supportive management. But medical science is constantly moving forward. We now have omavaloxolone, which is a disease-modifying therapy approved in some regions for eligible patients. It basically works by activating the NRF2 pathway. This boosts the body's natural antioxidant defenses, helping to dial back all that mitochondrial oxidative stress we talked about earlier. When you combine that with multidisciplinary rehab, close cardiology follow-ups, and orthopedic care, we are finally offering some genuine long-term hope to these patients. All right, to truly master this topic for the wards or your boards, you have to be able to distinguish it from the differentials. Look at how Friedreich ataxia and ataxia telangiectasia are both autosomal recessive, right? But spinocerebellar ataxia is usually autosomal dominant. Now look at the mutations. GAA repeats for Friedreich, a DNA repair defect for AT, and CAG repeats for SCA. And on a systemic level, only Friedreich ataxia hits you with that classic combo of cardiomyopathy and diabetes, whereas AT presents with telangiectasia. Keep this comparison table safely in your mental back pocket. And to make sure you absolutely never forget these key details, let's lock it in with the classic mnemonic Friedrich. F is for frataxin deficiency. R reminds us of the recessive inheritance. I stands for iron accumulation in the mitochondria. E is for that paradoxical extensor plantar response. D is for diabetes mellitus. R is for reflexes being absent. E is for early onset ataxia. I is for impaired proprioception, C is for cardiomyopathy, and finally H is for high-arched feet, otherwise known as pes cavus. Running through this mnemonic is a surefire way to keep all these concepts straight under pressure. We've covered a tremendous amount of ground today, from a malfunctioning GAA repeat expansion to multi-system failure, all the way to some really promising emerging treatments. So I want to leave you with a provocative thought. As disease-modifying therapies like omavaloxolone continue to advance, how might early, widespread genetic screening completely change the long-term landscape and the quality of life for patients with inherited ataxias? It is an incredibly exciting frontier in both neurology and genetics. Thank you so much for joining me for this explainer. Stay sharp out there and keep learning.